Psoriasis is a chronic papillosquamous disease which is mediated by T cells, and we have skin and other system involvement in psoriasis. To idiopathophysiology of this condition, the genetic predisposition along with environmental factors will cause activation of antigen presenting cells. The genetic predispositions are SOR1 gene and SOR1S2 gene mutations, and HLA-CW6 and HLA-B27 mutations is been associated with this condition. Along with this genetic predisposition, if the patient have environmental factors like infection with group A streptococcus, stress or physical injury, trauma, alcohol, smoking, and then intake of drugs like lithium, beta blockers, NSAIDs, and other drugs will trigger the activation of antigen presenting cells. These antigen presenting cells will release interleukin 12 and 23 to stimulate the CD4 plus T cells and T helper cells 17. So these cells will accumulate in the epidermis and the dermis, and they cause inflammatory response. During inflammatory response, they release inflammatory mediators like TNF alpha, interferon gamma, other interleukins, chemokines, and this causes chronic inflammation in these patients. All these effects causes decreased cell turnover, that is the proliferation of basal cells, stratum basale to stratum corneum usually takes 27 days. Now in this disease, it's reduced to 4 days. All this causes scaling and plaque lesions in psoriasis. We have different clinical types based on clinical manifestation. The most common one seen in 90% of patients is chronic or psoriasis vulgaris. Chronic psoriasis or psoriasis vulgaris seen in 90% of patients. The chronic or psoriasis vulgaris has papules and plaques which are erythematous with scaling, that is silvery white scale. The papules are raised skin lesions less than 1 centimeter. The plaques are raised skin lesions more than 1 centimeter. Here you can see the erythematous scaly lesion, scaling and erythematous plaque. The sites where we see these lesions are scalp and extensor regions of elbow and knees. Some of the signs which are characteristically associated with psoriasis, along with the signs which are elicited with the glass slide. If we scrape the lesion using glass slide, the lesion get attenuated, meaning it becomes more obvious. It is called as Grattage test, where the lesions become attenuated. If we continue to scrape, we'll get glistening white membrane, which is the last layer of dermal papillae. That is also called as Berkeley's membrane. And then if you don't stop, again you will continue scraping the lesion. Then you will get the punctate bleeding due to arteriolar dilatation. Arteriolar dilatation, because there is increased proliferation, there will be arteriolar dilatation. That is punctate bleeding. When you see a punctate bleeding, we'll call hospital sign positive. So first you will start scraping, the lesion get attenuated, cause it Grattage test positive. If you continue, you will see the Berkeley's membrane, that is glistening white membrane, which is last layer of derma papillae. If you again continue, you will see punctate bleeding, which are the dilated arteriole, that is hospital sign positive. We have hypopigmented ring around the lesion called as Voronov's ring, which is associated with this condition. Also, we have Cobner's phenomena positive in psoriasis, meaning if the patient has lesion and if he has trauma in the other sites other than the lesion, he'll develop the primary lesion at the site of trauma. This is called as Cobner's phenomenon. So along with the skin manifestation, we have nail manifestation. Those are pitting of nails along with subungual hyperkeratosis. We can see oil drop sign or salmon patch, which is a defect in nail bed. To call it as nail findings positive involvement, we should have at least more than 6 nails involved with more than 20 pits in each nail. If you see only one pit in any other finger, please don't call it as the psoriasis nail fainting. Then we have inverse psoriasis, where the lesions commonly we see in extensor region. In inverse psoriasis, we see the lesion in the flexure aspect of the hand and the knee. We have gutted psoriasis, which is seen secondary to group A streptococcus infection in children. They may give the history of pharyngitis. We see raindrop-like lesions on the back region. These are treated with macrolide antibiotics like erythromycin and all. Then we have pustular psoriasis, which can be generalized and localized form, where we see pustular lesions instead of the plaques or papules which we see in psoriasis. We have erythrodermic psoriasis, where more than 90% of body will be erythematous. More than 90% of body surface area will be erythematous with or without scaling. This is called as erythematous psoriasis. These are some types of psoriasis. Along with this skin manifestation and nail manifestation, 5 to 10% of patients has arthropathy, that is psoriatic arthropathy, which is asymmetric oligoarthropathy or symmetrical arthropathy involving distal interphalangeal joints. It is a seronegative arthropathy, where along with this joint manifestation, we see dactylitis, that is inflammation of digits. Management of this condition, we have topical therapy. In topical therapy, to normalize the keratinization, before that, to reduce scaling, we use emollients or moisturizer. We have, ciliary white scales we see in psoriasis. To reduce it, we use emollients or moisturizer. Then the primary pathology, which is inflammation and the increased proliferation, we reduce by giving anti-inflammatory drug like topical steroids, 0.5% betamethasone, or we can give the drugs which reduce DNA synthesis, thereby reduce proliferation like coal tar or dithranol. So, and also we can use the agents like tazorotene and calcipotriol, which is a vitamin A and vitamin D analog respectively, which normalizes keratinization. This is topical therapy. After topical therapy, we have phototherapy, where we can give the phototherapy helps by increasing the anti-inflammatory interleukins like interleukin 10. We have two types, that is narrow band type UVB lights phototherapy, and then we have PUA, that is sorrelin with UVA radiations are given. Narrow band UVB rays, where we give the UVB rays between the wavelength is the 311 plus or minus 2 nanometer. In PUA, we give sorrelin, which is a photosensitizer, which ensures the deep penetration of this UV rays. And then after giving sorrelin, which is an oral agent, we'll give UVA radiations to these patients, which is 320 to 400 nanometer wavelength, which has 320 to 400 nanometer wavelength. We have two regimes in psoriasis to treat psoriasis, that is Gokerman's regime and Ingram's regime. In Gokerman's regime, we have coal tar and narrow band UVB rays as a treatment modality. In Ingram's regime, along with Goka's regime, that is coal tar with narrow band UV phototherapy, we give dithranol or acitretin. This is about the topical therapy and phototherapy. If the patient has extensive disease, severe disease and resistant disease, we can give systemic therapy with anti-inflammatory agents, anti-immune agents like methotrexate, cyclosporin and acitretin. And then we can also give biologics like TNF alpha inhibitors like infliximab, etanercept, or interleukin 17 inhibitors like secukinumab. This is about psoriasis. To summarize, psoriasis is a chronic papillosquamous disease which is mediated by T cells, and it involves skin and other systems. Etiopathyphysiology of this condition, we have environmental factors and genetic predisposition causing activation of antigen presenting cells, which stimulates T17 helper T cells and CD4 cells, which causes the release of inflammatory mediators and inflammation. We characteristically see the reduced cell turnover from 27 days to 4 days. The clinical types are chronic psoriasis vulgaris, which is the most common type seen in 90% of patients, where we see papules and plaques. It is erythematous scaly lesions, which is silvery white lesions, seen in scalp and extensor lesions of elbow and knee. Signs are Voronov's ring, that is the hypopigmented ring around the plaque. We have the test with glass slide, that is Gratard's test and Auspitz sign. The nail involvement, we have pitting and subungual hyperkeratosis. The guttate type of psoriasis, where we see the raindrop kind of appearance. We have other kinds like pustular psoriasis, generalized, localized type, and ergomatic psoriasis. We see psoriatic arthropathy in 5 to 10% of patients, where we see asymmetric oligoarthropathy or symmetrical DIP joint involvement, that is the interphalangeal joint involvement with dactylitis. Treatment, we have topical therapy with tretinoin or calcipotriol. Sorry, not tretinoin, tazorotine or calcipotriol, which normalizes keratinization. The agents with relative scaling like emollients, anti-inflammatory drugs like topical steroids, drugs which reduce DNA synthesis like coal tar and ditronol. Phototherapy, we have narrowband UVB radiation or POA therapy. Regimes, we have Gokerman's regime and Ingram's regime. Gokerman regime, we give coal tar and narrowband UVB phototherapy. In Ingrams, along with these two, we give ditronol or acitretin. In severe disease, we can give systemic therapy with anti-inflammatory agents like methotrexate, cyclosporin, and acitretin. And biologics, we can give the infliximab and etanercept with a TNF alpha inhibitors, or biological agents, that is interleukin 17 inhibitor like secukinumab. Thank you for listening.